Thank you for watching the SAR lecture series. My name is Nushin Vadan and I'll start with the retroperitoneum. We start with anatomy and spaces. The retroperitoneum is divided by fascial planes into anterior and posterior pararenal spaces, perirenal or perinephric space. The paired perirenal spaces are two inverted cones, one on each side of the spine, and they contain the kidneys and adrenal glands. They are confined anteriorly by anterior renal fascia or Gerard's fascia, posteriorly by posterior renal fascia or Zucker-Canal fascia, and together they comprise the renal fascia. The anterior pararenal space is confined posteriorly by anterior renal fascia, anteriorly by posterior parietal peritoneum, laterally by lateral conal fascia. They contain the ascending and descending colon or pericolonic component and duodenum and pancreas or pancreaticoduodenal component, and continues across the midline. The posterior renal fascia, as opposed to common teaching, has multiple layers and is formed by opposition of two layers of fascia, the anterior renal fascia and lateral conal fascia. This creates a potential space extending from anterior pararenal space posteriorly in between the layers of the posterior renal fascia to, let's say, if you have a case of pancreatitis with fluid in the anterior pararenal space, can dissect in between the fibers of anterior renal fascia and lateral conal fascia, and we can see an isolated fluid collection just posterior to the kidney, which is between the layers of the posterior renal fascia. The posterior pararenal space is bounded by posterior renal fascia anteriorly, transversalis fascia posteriorly. Medially, it's limited by the psoas muscle laterally open to the flank, and inferiorly is open to pelvis. It contains only fat. Inferiorly, all three spaces, they interconnect and extend to pelvic retroperitoneum. As in this case of perinephric hematoma, extending to pelvis and iliac fossa. To your right, you see a schematic drawing that shows that superiorly perinephric space is open to diaphragm and the bare area of the liver. CT is the primary modality for evaluation of retroperitoneum, and MR is reserved as problem-solving tool. Cystic non-neoplastic process of retroperitoneum are the findings that we come across in everyday practice, like hematomas, post-operative conditions like urinoma, lymphocele, and seromas, abscesses, or post-pancreatitis collections like pancreatic pseudocysts, pancreatic or peripancreatic fat necrosis. We all are familiar with the appearance of the hematoma that's heterogeneously hyperattenuating on CT. In the acute phase, is high attenuation on CT and hyperintense on T1 and T2 MR. In the chronic stage, it's low attenuation on CT and low signal on MR due to presence of hemosiderin. As we see in this case of subacute hematoma, which is 8 days after nephrectomy, after right-sided nephrectomy, we see heterogeneous fluid collection in the nephrectomy bed due to different ages of the blood. Subacute hematoma, we see mixed signal intensity on both T2 on top and T1 in the bottom. Subacute hematoma. Urinomas are water attenuation collections that progressively they increase attenuation by contrast-enhanced urine entering the collection. When in doubt, you can always bring the patient back and prove that this is a urinoma by contrast-enhanced urine filling the collection. This case was brought back after 2 hours. Commonly, there's proximal hydroureter nephrosis, since the collection gives mass effect on the mid-ureter. Lymphoceles are collections of lymph without epithelial lining, often seen post-lymphadenectomy. On CT, they're homogeneously low attenuation. They can have lower attenuation foci of fat. The retroperitoneal fibrosis and IgG4-related sclerosing conditions are the most common solid non-neoplastic processes in the retroperitoneum. Rarely we come across pseudotumoral lipomatosis, histiocytosis, extramedullary hematopoiesis, and amyloidosis. Retroperitoneal fibrosis is idiopathic in more than 70% of cases. However, be aware of the secondary causes of retroperitoneal fibrosis. Most importantly, neoplastic process that causes secondary retroperitoneal fibrosis. Typically, the plaque is homogeneous, starts right below the aortic bifurcation, encases aorta and IVC, eventually the ureters, and does not displace the aorta and IVC anteriorly, as do lymphoma or metastatic lymph nodes. CT has the same attenuation as muscle, with avid enhancement in the active phase, little or no enhancement in the chronic fibrotic stage. On MR, the plaque is low to intermediate signal on T1, hyperintense on T2 in the active phase, hypointense on T2 in the chronic or post-steroid treatment. This is a case of retroperitoneal fibrosis evaluated by MR. You see axial T1 pre and post contrast images. Notice the plaque is surrounding the aorta and IVC is enhancing. However, a focal area in the left paraortic region is enhancing more than the rest of the plaque, and the same areas is T2 hyperintense. So this is a follow-up image after 1 year of steroid treatment. So the focal area of hyperenhancement is gone. Therefore, by MR, you can monitor the activity of the disease. Also, you can monitor the activity of the disease by FDG PET or Gallium-67 Scintigraphy, with high uptake in the active phase, little or no uptake in the chronic fibrotic stage. FDG PET can also detect the multifocality of the disease. If there's a question about that, if this is part of a fibroinflammatory condition like IgG4-related sclerosing condition. We all know that retroperitoneal fibrosis, among with other sclerosing conditions like sclerosing mesenteritis, sclerosing cholangitis, autoimmune pancreatitis, and inflammatory pseudotumor fall under the umbrella of IgG4-related sclerosing conditions. Keep in mind that in majority of the cases, the diagnosis of IgG4-related condition is done by the radiologist. So this is the case that we made the diagnosis. We have axial T1 post-contrast. You see multiple foci of hypoenhancement in the right kidney, and at the same time you have left renal hydronephrosis, since there is a retroperitoneal fibrosis that's not shown on this image, distally obstructing the left ureter. The image through the pancreas shows typical sausage-shaped pancreas, which is thickened with a thin hypoenhancing rim surrounding the pancreas, described as sausage pancreas seen in autoimmune pancreatitis. Also notice the intra- and extrahepatic biliary ductal dilation due to sclerosing cholangitis. Be aware of malignant RPF, seen in 8% of the case of RPF due to either desmoplastic response to retroperitoneal tumor or paraneoplastic fibrosis. We suggested the diagnosis since this is an atypical location for idiopathic RPF. So idiopathic RPF, we talked about that, is normally at the aortic bifurcation, and the biopsy was performed and came back as just fibrosis. They put the patient on steroid treatment for 6 months. However, the lesion grew. So second biopsy was performed with multiple passes and revealed carcinomas. So when the biopsy comes back negative and your suspicion is high, you can always ask for another biopsy. So often biopsy is required. Lymphoma is the most common cause of underlying malignancy in malignant RPF. Also, you can see this in sarcomas and carcinomas. Extramedullary hematopoiesis is common in liver, spleen, and lymph node, and very rare in retroperitoneum. However, we come across. sometime. On CT, paravertebral masses with or without fat on MR variable signal can have low signal on both T1 and T2 due to presence of hemosiderin, or high signal on both T1 and T2 due to presence of fat. And enhancement is often mild, as you see in this case. To your right, there's fat. This is a CT image that you see fat and soft tissue component within it. When you're dealing with primary tumors on the retroperitoneum, sit back and think that this could be a metastasis, or this could be arising from an RP organ. Among the primary retroperitoneal neoplastic conditions, we have mesodermal tumors, neurogenic tumors, germ cell or sex cord tumors, and lymphoid tumors that we're going to describe each entity separately. Keep in mind that up to 80% of the solid RP masses are malignant, not benign. Sarcomas. The most common sarcoma being liposarcoma in the retroperitoneum. Other type of mesodermal tumor being desmoid tumor, lymphangiomas, or picomas, perivascular epithelioid cell tumors. And that's a large category that includes multiple tumors like AML, clear cell Shukru tumors, or LAM. These are mostly benign tumors, but they have variable malignant potential. They have non-specific imaging findings, often large soft tissues with cystic and myxoid component, calcification, and hemorrhage. Liposarcomas are subdivided into 4 different categories. Well differentiated, that they can have, they primarily have macroscopic fat with streaky fibrous enhancing septations that you may not even notice these septations. Like in this case, the fatty component is large and only has a couple of thin septations medially. So therefore, keep in mind that a fatty retroperitoneal tumor is liposarcoma until proven otherwise, since lipomas are a lot less common than liposarcomas. Always suggest liposarcoma till this is proven otherwise. Myxoid tumors, they have water attenuation myxoid components that gradually fill with contrast. So as we see in this case, we have fatty components as well as multiple foci of water attenuation component. They're cystic, they measure water attenuation, they look cystic, but they're pseudocystic. On the delayed images, they gradually fill with contrast. Dedifferentiated liposarcomas, they have fatty and soft tissue component, and they can have calcifications in 30%, which helps with the diagnosis. That means that lower grade tumor is dedifferentiating to higher grade tumor. Pleomorphic or round cell liposarcomas, they have little or no fat. So it's impossible to distinguish these or suggest liposarcoma without biopsy. They look the same as other RP tumors, so they have little or no fat. Another thing to be aware of is that when you're dealing with a fatty retroperitoneal tumor, think that is this arising from retroperitoneum itself, or is it arising from a retroperitoneal organ? Like in this case, we have a typical beak sign. That means this defect that's arising from the left kidney. So notice this large fatty mass is arising from the left kidney, and this is described as beak sign. The other finding is the feeding artery sign that is connected to the left kidney on this case. So this large fatty mass is arising from the left kidney. It's not a liposarcoma. These two are renal AMLs. Leiomyosarcomas are primary IVC tumors. They're very large, more common in female. They can have necrosis and hemorrhage. Calcification is very uncommon in these. Most commonly, they're extravascular tumors, like being outside the IVC. Only 5% of them can have intravascular component, and you can have combined like extra and intravascular in 1/3 of the cases. They grow large and metastasize late. So if you have a large retroperitoneal mass with extensive necrosis and contiguous involvement of the vessel, think IVC leiomyosarcoma. In this case is a young male with history of total conectomy. You have a soft tissue mass involving the retroperitoneum and mesentery. So the total colectomy is a buzzword. So you get suspicious that this patient probably had FAP. So the patient had Gardner syndrome. What do they get? Desmoid tumor. So this is a desmoid tumor in the root of the mesentery and involving the retroperitoneum. So they're benign tumors of fibrous tissue. Usually multiple can be found within the abdomen. Increased incidence in Gardner syndrome, but majority are sporadic. Gardner syndrome is FAP with extracolonic manifestations. Desmoid tumors are associated with abdominal surgeries and trauma typically recur after surgery. Lymphangiomas have the typical look of simple and multiloculated cystic spaces that insinuate in between normal structures without invasion. They can have negative attenuation area due to presence of chyle. They may have calcifications. Once you put the ultrasound transducer to biopsy the lesion, you notice that it's predominantly cystic, so you get suspicious that this is probably lymphangioma, not a solid tumor. So a diagnosis is easier on ultrasound than CT. Moving to neurogenic tumors, be it nerve sheath tumors like schwannoma, neurofibroma, malignant nerve sheath tumors, you should be suspicious if there's fast growth, pain, irregular infiltrative border, if the patient is younger, has NF1, has radiation exposure, or arise from ganglion cells like ganglioneuroma, ganglioneuroblastoma, or neuroblastoma, or paraganglion cells like paraganglioma, pheochromocytoma. Pheochromocytoma basically arises from adrenal medulla, but paragangliomas are extraadrenal pheos. When small, schwannomas are round and homogeneous, as you see in this case of the left paraortic mass, which is homogeneously enhancing and is round, well-defined. However, when they're large, they're heterogeneous, as seen in this right retroperitoneal mass. They can have cystic changes, central hemorrhage, myxoid stroma, calcifications. They are typically encapsulated and extend along the nerve in the paravertebral or presacral region, more common in female. Neurofibromas, they have this typical target sign that's described in T2-weighted MR. On T2-MR, they have a typical hyperintense rim and relatively hypointense center due to dense central collagenous stroma. More common in male, they can be isolated, but if you have multiple neurofibromas, think NF1. Unlike small sporadic neurofibromas, when you have plexiform neurofibroma, this is pathognomonic of NF1. These are like sheet-like masses, they're large. You can see in the retroperitoneum, can extend to the mesentery. You can see it along the paravertebral region. They're dumbbell shaped, fusiform, they course along the nerve. You can see low attenuation areas in the CT due to presence of lipid. They're typically hyperintense on T2. They can give atrophy of the muscles supplied by this. They can give widening of the neural foramina and scalloping of the vertebra. Ganglioneuromas, they're benign, younger age group, up to 50% functional with secretion of catecholamines and androgenic hormones. They arise in the typical location just posterior to IVC or on the other side at the same level on the left side, medial to the adrenal glands, where the sympathetic ganglia live bilaterally medial to the adrenal glands. So they had their paravertebral and they insinuate between normal structures without invasion, just like lymphangiomas. They can have speckled calcification in 20%. Typical world appearance has been described on T2-weighted MR due to this circular areas of both T2 hyper and hypointense area. They're typically hypointense on T1. Paragangliomas, they arise from para-aortic organ of Zucker-Candle, a more malignant rate than pheochromocytoma, so 40% malignant, 40% functional with secretion of catecholamines. They have hemorrhagic necrosis causing fat fluid levels. Paragangliomas, when they're small, they're homogeneous, like in this case, to the left of the aortic bifurcation. You see homogeneously enhancing lesion, a small paraganglioma. Germ cell tumors can be seminoma or non-seminomatous germ cell tumors. Primary sex chordostromal tumors are very rare, more common in female, and they have non-specific imaging finding. Keep in mind that only 1 to 2% of germ cell tumors are extragonadal. So most germ cell tumors in retroperitoneum are metastases from gonadal origin. When you have a biopsy diagnosis of the germ cell tumor in retroperitoneum, you need to perform testicular ultrasound looking for the primary. Teratomas they have solid and cystic components, more common in kids. They can have fatty component or no fatty component. Like this case, they didn't have any fatty component. They can have fat fluid level that is described as pathognomic for these tumors, but also reported in liposarcoma, so it's not pathognomic for teratomas. They can rupture with peritoneal or retroperitoneal fat fluid levels. This is a case of retroperitoneal tumor that was biopsied, and biopsy revealed choriocarcinoma. We performed a scleral ultrasound that revealed only a focal calcification without any mass. This is typical of burned out germ cell tumor. That means patient had a choriocarcinoma in the testis that metastasized to retroperitoneum, and then the primary tumor burned out and only a focus of calcification is remaining in the testis. Lymphomas are the most common RP malignancies. They surround the structures without compression. A typical floating aorta has been described since they lift the aorta and IVC from the spine anteriorly. Other lymphoid tumors being post-transplant lymphoproliferative disorder, extramedullary plasmacytoma, and Castleman disease or enhancing lymph node syndrome. Keep in mind when you're dealing with retroperitoneal masses and tumors, think that is this non-neoplastic process or is it neoplastic, meaning that could be metastasis, could be arising from primary retroperitoneum itself or from an organ in the retroperitoneum. Think about the tumor characteristics, like does it have fat, solid cystic component, fluid levels, vascularity and calcification. If the patient is younger, think neurogenic tumors, germ cell tumors, lymphangiomas and desmoid. Check the labs, since ganglioneuromas, paragangliomas, and germ cell tumors can be functional. And think about the pattern of spread. If the lesion is extending between normal structures without invasion, lymphangioma, ganglioneuroma, lymphoma, or neurofibroma. If the lesion has fat, liposarcoma, teratoma, which can have fat fluid level, PEComa, extramedullary hematopoiesis. Myxoid stroma, think myxoid sarcomas like myxoid liposarcoma or neurogenic tumors. If there is tumor necrosis, think sarcoma, especially IVC leiomyosarcoma. Also, paragangliomas, they show hemorrhagic necrosis with fluid levels. So when you have a retroperitoneal fibrosis in your mind, make sure that report it, since majority of the RPF and IgG4 related sclerosing conditions are diagnosed by radiologists. Up to 80% of the solid retroperitoneal masses are malignant, so more malignant potential than benign. If you have a fatty retroperitoneal mass, it's more likely being liposarcoma than lipoma. And these are the imaging clues that we gave you just to narrow your differential diagnosis in the report. However, biopsy is needed in majority of these cases. With this, I thank you for your attention.